Welcome to Self-Discovery Media Network, formerly known as Self-Discovery Radio. Each week we bring you illuminating shows from those making a difference in the lives of others. They've taken their own journey. They're here to share their skills, their wisdom to help you on yours. You can see more about us at selfdiscoverymedia.com, and please listen to our wonderful collection of shows. Our next show is...
Great. Hello, everyone, and welcome to Recovering the Whole of You. My name is Dr. Kiti Adderley, recovery expert and physical therapist, owner of Handling Your Health, Wellness, and Rehab in Nassau, Bahamas. I am so happy to have with us today Dr. Ebbie Jackson, and we will be discussing Low Vision Awareness Month and macular degeneration. Dr. Jackson, thank you so much for joining us. Please tell us a bit about yourself.
Kitty, good afternoon, and thank you so much. It's a pleasure to be a part of your show this afternoon. My name is Dr. Ebbie Shearer Jackson. I live in the beautiful Bahamas, particularly the main island, Nassau, Bahamas. I'm an optometrist by profession. I've been practicing in private practice for the past 26 and a half years. And I've also worked in pediatric optometry in public health for about 12 years. I'm an avid runner, marathon runner. I've been through cancer treatment and therapy. And so, yes, thank God I'm still here today. I'm a musician. I'm an advocate for a lot of different causes. I'm also part of a radio talk show in our country, talking about challenges and things that we face in our country. And amongst other things, I'm just about helping people and trying to make my contribution.
Great. Thank you so much. I know that's just the tip of the iceberg, but we'll delve in. I'd like to say that you're also my optometrist. So my wonderful glasses that I'm modeling comes from Palmdale Optical.
Yeah, they look nice on you. Palmdale Vision.
Yes. Thank you. I'm wearing them well. Sometimes I get a bit vain and take them off because of the glare, but I am one of those people that suffer with impaired vision. It's not where it needs to be for many reasons, probably reading too late in the night, not with the right kind of lighting, probably using the computer screen that wasn't set at the best setting. But yet here I am, pretty good vision now that it's been corrected with my glasses from Dr. Jackson. And so, you know, as she worked with me, I just felt that she had so much to offer generally in terms of low vision and how we can prevent vision loss and actually talk about recovering your vision, making it better. So we'll just let her start with letting us know what are probably the top causes of vision loss you see.
In our country in particular, and being a predominantly Black country, some of the main challenges that contribute to low vision, Dr. Kitty, are hypertension, diabetes, glaucoma, and macular degeneration to a very small extent.
Okay.
Hypertension, diabetes, strokes, they are the main contributing factors to low vision. And in some cases, what I'm noticing also with young women who go into preeclampsia, pre and post pregnancy, they're starting to show a lot more of challenges with bleeding in the, and it's related to hypertension in most cases. So those are the three main contributing factors in our environment that predisposes a person to low vision. However, you can get low vision from an injury, and just about anything pretty much that affects your vision. But I want to tell you particularly what low vision is. And low vision is a condition, it's caused by an eye disease, okay? And when your visual acuity, the ability to see a certain size letter is a 20/70 or worse, in the better seeing eye, then, and it cannot be corrected with glasses, contact lenses or anything, then you're considered to be low vision. Okay. So if it's 20/70 or more in your better eye, you are then considered to be low vision. And another big cause of low vision here in our country, believe it or not, is cataracts. Okay. All the patients who choose not to have cataract surgery and their vision deteriorates over time, they're considered low vision patients until they have it removed. So those are the main contributing factors that we see here in our community that provides and causes more problems for low vision patients.
Okay. So I want to leave hypertension and diabetes to the end because those are sometimes modifiable with lifestyle choices. In terms of the glaucoma and cataracts, can you speak more to those? What causes glaucoma and what causes cataracts?
First of all, cataracts. Cataracts, when you look at a person's eye, in each eye we have a structure called a lens. And that lens has the ability to bring items into focus on the retina to enable us to see properly. However, with time and aging, and of course, living in the tropics like we do, we're exposed to a lot of sunlight. Even when the sun is not out, I mean, the rays are still penetrating. And therefore, with the sunlight, the UV rays coming from the sunlight, and aging, the lens just automatically deteriorates with time and maturity or aging. And so over time, as it deteriorates, the ability to bring images on the focus images on the retina becomes a problem. And so the vision deteriorates over time. Now, these people tend to complain a lot more of night driving, glare issues in particular, and the ability to not be able to see depending on the illumination that they're in.
Okay.
So if you choose not to have the cataract removed, the cataract can and will decrease your vision over time and almost make you blind if you choose not to have it done. So in Nassau here in particular, there are some patients who you're seeing it among, but in a lot of our family islands where the access to healthcare is not there like it should be, a lot of these older patients just choose to exist in their condition and eventually leads to blindness or impaired and low vision. So that is what a cataract is. The next one you asked me about is glaucoma. Glaucoma is a very common disease you find in people in the Black population also. You see it a lot in Native American Indians, and so it's in the white population, but we see a lot more of it in our Black population. And what happens is that pressure is produced in the eyes to help nourish the tissues and to maintain its shape. And with time and aging, this pressure starts to increase. And when it increases, it impacts the optic nerve, which brings vision to the eye. Okay. And as a result, it squeezes the nerve. And as it squeezes the nerve, it starts to cause damage to the nerves that are on the periphery. Now, when we think of it, think of a cylinder. Okay, a cylinder has fibers in it. So you have inside fibers and then you have fibers on the outside.
Okay.
So if the pressure increases, the damage starts with the fibers on the outside of the cylinder. And therefore, these fibers transmit vision to the eye to enable us to see properly. So the pressure squeezes the nerve, impacts the vision, impacts the fibers on the outer ring, and they tend to get damaged more quickly. And so it damages your peripheral vision. And a lot of times people don't know this is happening.
Right.
And eventually the damage just moves to the inside and then it damages the internal fibers. And that can cause a person to eventually be blind or end up with low vision. Now, here in our country, we find that a lot of patients at times don't necessarily come in to have an eye exam unless they're having a problem. And the thing with glaucoma, we say it's an insidious disease because in most cases there are no signs or symptoms, especially earlier on in the disease. Now, when you start to have problems, chances are the disease is in its latter or late stage.
Right.
But what happens is that this pressure slowly increases over time and it impacts the optic nerve and they start to lose their peripheral vision, and you find a lot of times they have to turn to be able to see things coming from the side, and eventually it impacts the central vision and leads to blindness. Now, it is common. It goes undetected in a lot of cases, and we're seeing a lot more of it even in juveniles. And I think the reason being is because we're better able to detect it now. It's been a disease around for a very long time, but we're better able to detect it. So we're seeing a lot more in the younger population, juvenile. And it has a family hereditary attachment to it. Chances are, if it's in your family, the chance of developing it with time and age increases the risk. And so a lot of times I say to patients, if I'm saying that they're looking like they could potentially develop glaucoma, the first thing I tell them to do is go home and check your family history, because that's important. And a lot of times we don't know our family history, but I tell them, go and inquire, find out if someone in the past, maybe on drops or having problems seeing or can't see or went blind or anything like that. And then you start from that basis and try to manage their disease.
Okay. So with cataracts, we would correct it by surgery. What is the correction for glaucoma? How do we manage glaucoma?
Glaucoma, you want to start first with first line of treatment. You have a lot of people who are listed as what we call ocular hypertensive, meaning their pressure is above normal, but not high enough. And there's no damage showing of the optic nerve or their field of vision to start treatment at that point. So we manage them, and treatment would be regular follow-ups every 3 to 6 months, depending. And also they would have to do what we call a visual fields. And there are other instrumentations that are used now to tell whether the nerve is being damaged. So they would have to do some of those testing just to confirm if it's glaucoma or should you start treatment. Now, once treatment is started, first line of treatment would be drops. And we would try to start with 1 drop, to manage the amount of drops patients are using, because the drops can increase depending on what the pressure is showing. So first line of treatment would be to start with maybe 1 drop. If that does not control it sufficiently, then you need to add another drop and then another drop. And in most cases, sometimes a lot of patients are on an average of 3 to 4 drops, depending on what pressure readings they're showing and the type of damage they may have already accumulated. Second line of treatment would be drops along with laser treatment. And we call that a peripheral, where they go into the pupil and they make a hole in the pupil, through with laser. And this enables the pressure to drain out a bit faster in order to lower the pressure. Now, with the drops, it's either, there are 2 types mainly. You want to increase outflow or decrease production of the fluid. So treatment starts with either one or the other. The type drops that you choose to put the patient on, it's either to increase outflow of the fluid or to decrease the production of it. And then the second thing would be to add laser along with that if the pressure is not being controlled sufficiently. Now, if that does not control it to what you need to have in order to help the patient, third line of treatment would have to be glaucoma surgery, where they would go in invasively and put in a pump in the patient's eye to help that fluid drain out even faster. And you still will have to continue with your drops.
Okay. So it really highlights the issue of early detection, and so we can have early intervention.
Yes.
So as we talk about early detection and early intervention, what is the time frame that you recommend for eye examinations?
I say today now, we don't live, when we were growing up, I'm sure, Kitty, you didn't go and have an eye exam until you had a problem.
Right.
Okay? Nobody considered the eye being that important. If you could see and do what you needed to do, you didn't need an eye exam. I think, of course, a lot of times families could not afford to do it if you had more than 3-4 children. So you took those who had a major problem. But in our day and age, with technology being the driving force, I say to persons all the time that if a child is not showing any major problem or concern before age 5, at least by age 4 or 5, when they start grade 1 or preschool,
Right.
they should have an eye exam.
Okay.
You cannot assume today that because they're not complaining that they're okay. And so I say to them, in this day and age now, that is when we need to start. Now, of course, for adults, we should be doing it on a regular, consistent basis. But for our children in particular, they need to start at grade 1. So you will know the overall visual status of your child, and then know what sort of challenges this child may have going forward.
Okay. So you said regular for adults. What does regular mean for you? How often should we get in there to see you as adults?
I say to patients, if they're not prescribed any sort of visual need, whether it's glasses, contacts, or whatever, and they're doing okay, and no medical conditions related, every 2 years is okay. You shouldn't go no more than 2 years.
Okay.
But if you're wearing glasses, if you're wearing contacts, or if you have medical conditions, in some cases, we may have to bring them in sooner, every 3 months, 6 months, but at least annually for those patients in particular. And now why we're saying annually for everybody, because we're all using the computers now. Okay, we're on phones and we're on computers. So digitally, everyone should be checked, because a lot of times you see symptoms of red eyes, persons are complaining of watering, itching, all of these are concerns. And in a lot of cases, it is computer related, but they don't realize it. So for us now going forward, these are things we should be doing annually.
Well, I know in my intake form, my medical intake form with my patients, I ask them the last eye exam, and a lot of people are a bit perturbed. Why do you need to know about my eyes? Specifically, if I have a patient coming in with headaches, neck pain, upper back pain, and shoulder pain, I need to know when was the last time their eyes were checked, because many of us, when we're having vision issues, we're craning forward or we're pulling back, so you're making the neck do abnormal movements, and multiple or repetitive abnormal movements can cause movement dysfunction and tissue dysfunction. And so before we start blaming other things, let's make sure that the eyes, the vision is where it needs to be, so that the body is not compensating to try and put things in the right position for you to read. And so that's a big thing for me. And I realized that a lot of people aren't keeping up with their examinations as they should, or if they actually do have contacts or glasses, they're not compliant with its use. So I always send patients to the optometrist, because I know that's a big part of their overall physical health as well. And people don't put it together, but when you sit down and explain it to them like that, it makes sense. And definitely with the technology, we see it again with the positioning of the head. The neck comes into play, and we have all those nerve issues with the thumb and tendonitis with the thumb. So, you know, it's something that we need to keep promoting, and really getting people to focus and understand exactly how technology can actually cause issues as well.
Kitty, you are so correct. You're smart, my dear, because people don't necessarily realize how the body is connected.
Mm-hmm.
You know, this is one system, but there are connections. And so sometimes, a lot of times they're referred pain, but they don't realize you could be having an issue somewhere that's not related to that, but it's stemming from somewhere else. And so, yeah, they get baffled when you say, if you go to have your teeth or whatever, like, why are you asking me this? So that's not related, but the body is related.
It's related. Okay. It's one organism, organism.
With the different extensions. And when there's a deficit in one, it's going to affect the other. Mm-hmm. But another big issue today is also ergonomics.
Yes.
Okay? Place.
Yes.
That is major issue today that's creating problems that I'm sure you're seeing on a much more regular and frequent basis.
But that's a whole. Mm-hmm.
Yes, and sometimes when I say to patients, listen, you may need 2 pairs of glasses depending on what you're doing.
Right.
You know, for us, we think, why do I need to have more than 1 glasses? But in this day and age of the different things that we do, depending on what we do, you may need correction just for that particular situation. So I say to them, listen, ergonomics is a big problem today. How do you sit when you work? How far are you from your computer? How are you looking? What are you doing? Where are your feet? How are you sitting? All of these are important because, yes, it does impact the vision, and then it impacts the body. And so they start to develop symptoms that seem unexplained, but it's
Right.
one related to the other. So definitely a big problem in this 21st century.
So I'll tell you a bit about ergonomics as well, where the computer monitor screen is positioned, right? So we're taking it for granted that everybody's going to be using a desktop, but how many people grab their laptop and go into bed and they're leaning on one side of the air, or they're craning over it on the lap, or my favorite position, and I'm being very sarcastic, is lying on your tummy with your head tossed back like this, trying to look into the screen. All of these things are creating a whole sequelae of events that your poor body does not need to manage, right? So I think we just need to keep on parlaying off of each other to make sure we keep our people healthy and moving properly and seeing properly.
Definitely. And you know what's another problem? The type lenses that we wear.
Okay.
You know, initially, if you wear what we call a single vision lens, that will correct you for a particular time and space.
Okay.
Now, as you age and you go into progressive lenses and you're using these digital machines, now you have to adjust the way you've been seeing all along to be able to compensate.
Right.
In order to have visual efficiency. So there's so many factors involved. And you know, the big key about it is education. People have to constantly be educated as to this is what's happening. This is potentially what could happen. So you need to pay attention to certain things.
Definitely. And I'm going to confess that I realized that I was having challenges. I was doing a lot of studies, and I realized that my old prescription wasn't doing it for me. So I kept going and buying these little readers, the cheap readers. They're cute. They're really, really cute. But I wore readers probably for the better part of 6 to 7 months, and I knew better. I should have gone in and had a proper examination. And I realized that probably could have caused me more damage in the long run instead of trying to have a quick fix. So could you just speak to readers? I know we talked about examinations coming in, but is there any information you would like to say about the readers that we find on all of the pharmacies and drugstore desks and countertops now? Even in the food stores, they're selling them.
I say to persons, readers are good to have for quick fix.
Okay.
If you're traveling, if it's an emergency situation where you need to fill out forms or you need to do something quickly, readers can help for that. But readers they're not good if it's not your actual prescription.
Okay.
Now, persons who are just farsighted can get away with a particular reader depending on the prescription. Even nearsighted persons to an extent, depending on the strength of their prescription. But in general, you find that persons who use readers have an underlying astigmatism component attached to that. And the readers will help for that particular time. But over time, the readers probably causing their eyes to get become worse. Okay. And so you find they try, and then eventually they show up. So, doc, I've had enough now. I need to deal with this. So readers are good because, in certain situations, if you lose your glasses or if you need to fill out a form quickly, you're traveling, things like that, you can pull them out to help you. But they're not things that you should use for studying or being on the computer on a consistent basis unless they were prescribed to you by your eye care professional.
Okay. So thanks for that tidbit. I am a reformed reader user, so.
Oh, I see some patients who have tons.
Because they're cute. You can get them to match every outfit, know?
Yes.
But definitely. So February is also Macular Degeneration Month. We don't see it much in our population, but could you speak to that a bit?
We see it, but it's not to the extent that it really damages the vision where they become so impaired, visually impaired. Okay, but you see degeneration in a lot of the patients. However, the vision stays fairly stable, and that's a good thing. And I think a big part of that is the fact that because we're dark-skinned, we have pigmentation in our skin, and we also have pigmentation in the retina.
Okay.
You find that macular degeneration is much more common in the Caucasian population because they have less pigmentation, so damage happens more quickly and rapidly. But somehow I think because of pigmentation in our retina, even though you see the damage or the changes taking place, it's not as advanced as those in the Caucasian population. But we have patients with it, but we don't have that sort of visual impairment to that degree as you would see in the Caucasian population. So a lot of patients are taking when you say medication, I mean, we put them on the vitamins, lutein and things like that, because what is happening is that there is a deterioration of that item lutein that's normally found in the tissues of the macula. And they're doing research, and you're seeing where some patients are getting vision improvement as a result of the advanced technology that's available today. But fortunately for us here, even though we see it, it does not cause the patient to become so visually impaired or become low vision. But it may just reduce the vision slightly. But I've noticed a lot of patients are really saying, well, only a small percentage, say less than 5% where they're, and in most cases, that's probably a familial kind of situation where family hereditary disease condition.
Okay, could you just explain to us what macular degeneration is for those of us that may not be completely familiar with its process?
Okay, it's a deterioration of the macula, or the area in the back part of the retina that controls your vision. Now, in the back of the eye, you have the retina. The retina occupies almost 80 to 90% of the eye, and that controls peripheral vision, side vision. But there is a small area in the back of the eye called the macula. And in that macula, there is an even smaller area called the fovea, where we get our best vision. So think about it. As the eye moves around, if the eye is not aligned onto the macula, you're not seeing very well centrally for detailed stuff. You notice some patients, they may turn to the side or whatever. The periphery of the retina does not give us that kind of vision. So persons who may have an eye that's misaligned, persons whose eyes are turning out, their vision would tend to be reduced because the light is not shining directly on the macula. But that little area, those tissues and cells start to degenerate. In a lot of cases, unknown reasons. You can't tell why it happens. But they're predisposed to having that degeneration, and over time, it affects their central vision in particular. So they start to lose vision over time. But it's a disease condition that affects the macula, which is the part of the eye that controls central vision and gives you your best vision in most cases.
Okay. All right. So that's a lot of information so far. So I don't know if we save the best for last or the worst for last when we talk about hypertension and diabetes. You know, they're dear to my heart. Unfortunately, we seem to see a large amount of people in our population presenting with these two chronic diseases. For the most part, they're preventable and they're able to be controlled. They're what we call sometimes lifestyle diseases. There are some risk factors that you can't get away from, but for the most part, we know that you can avoid high sugars, that you can avoid some foods that may increase your blood pressure. But we seem to have a challenge with getting people to understand that and pay attention to what's happening in their bodies in terms of blood sugar and blood pressure levels. I'm studying right now to become a diabetic educator. And it's just amazing the information that I'm getting, things that I wasn't aware of as a health professional for more than 18 years. So by the time you see people presenting with signs and symptoms of diabetes, the neuropathies, the impaired eyesight, that means this disease has been present for a very long time. And you mentioned it before, especially when you talked about glaucoma, you know, that there were signs and symptoms there before, or sometimes they're subclinical. We don't even recognize them. So, you know, I'm very passionate about getting this message out. And so, you know, you really want people to have a full functioning life. And when you think about losing your vision, you really lose a significant part or opportunity to interact with your surroundings. So could you speak to hypertension and diabetes, what you see in your practice, and how do you sort of manage your patients that present with this condition?
Yes, here in the Bahamas, two major diseases, lifestyle diseases, diabetes, hypertension, plus the hereditary factor involved.
Right.
And so I'm telling you, as we age as a population, diabetes and hypertension are the two presenting factors. Most patients who come in, and when we do fill out the history, they either have it or family history of it. Very few patients, especially older patients, after age 35 going into 40, who are not hypertensive or have diabetes. And so it's a common factor that we see in the day-to-day, and particularly in my clinic, I see a lot of them. Now, fortunately for some, the thing that I've noticed with diabetes, it attacks one particular major organ and it beats it down.
Mm-hmm.
I've seen patients with high glucose reading that's impacting the kidneys or maybe an extremity, but the eyes are okay.
Mm-hmm.
Okay. And then I've seen patients one particular patient, I'll never forget her. This lady was only about 90 pounds most of her life. I knew her a very long time, all my life. And she was seeing another eye care professional for our exams. And one afternoon, she showed up to my office. I can't remember why or whatever, but she may have been having issues, and she came to the office. And as I examined her, and when I looked in her eyes, I said, who have you been seeing on a consistent basis? And she said to me, I said, have they ever looked in your eyes? And she said, yeah. But at that point, when I looked in her eyes, there was so much bleeding. I was shocked, because I said to myself, if this lady is seeing somebody on a regular basis, they must have seen the damage and the bleeding that's been occurring. And it did not start overnight. You can see the long-term damage. So I asked her if she was hypertensive or diabetic, and she told me no, she was never diagnosed with it. I took a pressure. Pressure wasn't that much elevated. But right away I knew that she had severe diabetes.
Mm-hmm.
So I said to her, now listen, I need you to, when you leave my office, and this is like close to 5 o'clock, I told her she needed to go to the walk-in clinic to have her pressure done and diabetes and check for diabetes, glucose, right? And so, yes, the very next day she called back and she said they told her she has advanced diabetes and pressure wasn't too bad. But this lady, her vision degenerated over time and rapidly. Now here it is, she's only 90 pounds, very thin. If you've seen her, you would never associate her with having diabetes. Yet I've seen patients who are obese or who just not controlling their sugar level, glucose level, but yet no damage to the vision. So from what I'm saying, diabetes attacks one particular organ, and which one it chooses to attack, it beats it down and beats it down over time. So a lot of times patients will come in and glucose readings are high. Now the one main vision challenge that they would have is that they can't see.
Okay.
Okay. They will come in and say, Doc, I found out I have diabetes. They started me on medication. Now I can't see. What happens is that as your glucose level increases, you don't realize it's impacting the lens in the eye. So the lens is starting to swell. Okay. And it gets to a point where it throws the vision totally out of whack.
Okay.
Now, once they start to have symptoms, because by the time they come in, I'm saying to them, listen, are you frequent urination? You're having tingling, itching, things like that. They said, listen, you have diabetes or you're moving in that direction. So if they're not diagnosed before I see them, I would send them on to listen, be checked, you need to have that managed, and then you need to see me once that is controlled, because there's nothing much we can do with the vision. Once they start a patient on treatment or medication, what happens is that as the glucose level decreases, as it decreases, then because the lens was moving in one direction for so long, now it starts to move in the other direction. And so it throws their vision totally out of whack. So the first thing they would say, I can't read, I can't see. Because during that time, that transition period where the lens was increasing or swelling, and then as it decreases, the vision decreases and then improves over time. So for those patients, we have to send them for treatment. They need to be managed, and we see them like maybe 2 months down the road to see what the visual level is showing. Because if I give them a prescription, say for that,
right,
a week or 2 weeks later, they cannot see with that particular prescription, and then so on and so forth. So that's what happens in particular with diabetics, where it throws, we call it a hyperopic shift, where as a result of the increase in glucose, and then once they start treatment, the reverse occurs. So therefore, they cannot see during that interval. Now, once they're managed and their glucose readings are controlled, they see okay. But in terms of the retina, the back of the eye, the damage, diabetes cause bleeding of the blood vessels in the retina in the back of the eye. Now, what happens also? Increased glucose weakens the blood vessels. So they start to bleed. Once blood vessels weaken, they start to burst and bleed. And when they bleed, depending on where the bleeding occurs, it can affect your vision severely. Okay. If it happens in the periphery of the retina, they can still manage to see okay, but you need to control that, because if bleeding continues, it's going to impact the vision over time. But if you see bleeding starts occurring in the macula, where we get our best vision, then the chance for vision improvement decreases with time. So these patients now have to have injections to manage Avastin injection, to manage the bleeding and to help control it. And in some cases, vision may improve, in other cases, it may not. Now, if you are a juvenile diabetic and that starts to impact your vision or it affects the eye, unfortunately, these persons, depending on the extent of the disease, can really end up becoming low vision or visually impaired. Okay. Case in point, when I was studying in school, one of my colleagues was a juvenile diabetic, pretty much all her life. And the one organ that it impacted was her vision. So her vision deteriorated because she had so much severe bleeding in her eyes. They had to treat her, and of course, treatment would be laser treatment to burn the blood vessels to stop them from bleeding. But in the process of burning these blood vessels, you're damaging good cells.
Scarring as well.
Yes. And so the chances or ability to see does not improve. And eventually, with so many burns and holes in the eye, what happens is that the retina starts to pull away and detaches. And eventually, that's what happened in her case, and she went totally blind and had to really leave school and learn Braille and change her course of action in terms of her profession, because she went totally blind in both eyes. So diabetes can beat and impact the eye in such a way, and we see it all the time. And a lot of times, by the time the patient comes in, a lot of damage has already occurred. You know, they know they have diabetes, and I say to them, does your primary doctor say to you, listen, have your eyes checked or whatever? In a lot of cases they do, and in some cases they don't. And so the patients don't. I saw a patient Thursday, He's a juvenile diabetic and he's now an adult, and he's never had an eye exam. So I was like, what? It just didn't make sense to me. You're seeing a doctor on a regular basis and they're not insisting that you have your eyes checked. So we see it a lot. Diabetes is really reaping havoc in our community. And the cost for treatment is so horrendous. In most cases, a lot of times, the people cannot afford it. So if they don't try to prevent themselves from getting to that point, when they get there, then they can't afford the treatment.
Wow. And we see it. And I like what you said, because what it really shows is that we need a collaborative approach to healthcare, to wellness for our patients, because you can pick up signs and symptoms of diabetes by checking for the bleeding in the eye. When we have patients that come in physical therapy, due diligence is that you check sensation at the bottom of the feet, you check balance, and you check proprioception. And we realize that diabetes is taking a toll on the nerve. So it's usually the nerve tissue, the eye organ, the eye tissue, as well as I think it's the kidney, the renal tissue. Those seem to be the most susceptible to diabetes. And so we're seeing people presenting with neuropathies, and we're able to pick this up and say, something's going on here. Are you diabetic? Have you ever been tested? And when we send our patients to follow up and refer them to the specialist or the endocrinologist, they're realizing that, hey, they are testing positive for diabetes, and how long has it been there, and how much damage is done. So this really highlights and emphasizes the fact that we really need that we really need to do due diligence and push our patients, have a holistic, collaborative approach to patient care. So the signs and symptoms you see in diabetes, it sounds almost similar to hypertension. Would you say so, or is there anything else?
Pretty similar. Pretty similar. Just that once that pressure starts to increase, of course, it's going to impact the blood vessels again. And, you know, you could only apply so much pressure to a blood vessel. What do you think will happen?
It will
burst. And that's what the same scenario happens when it comes to hypertension. The pressure is so high, blood vessels burst. And when they burst, depending on where the bleeding occurs, it can affect the vision. You know, strange enough, in the last month, I saw two young ladies in particular. One had preeclampsia, one had post. And they both ended up with damage in the back of the eye. Okay. One did not have bleeding, but it affected the macula. Her vision is starting to improve. The other one had such severe bleeding, we'd have to see over time if the vision does improve. So it's pretty much similar, and treatment is pretty much similar, where they need to inject the eye to minimize the bleeding, depending. And in some cases, like in the other young lady who didn't have bleeding, you just have to leave it and hopefully it would resolve over time. And hers improved tremendously. Going back to diabetes, I remember seeing a patient, also a very young lady, who was referred to us because she was having a lot of issues with her vision. She was seeing someone for a long time, using contact lenses. And for some reason, she felt like something was wrong. So she was referred to our office. When she came in and I saw her, very thin young lady, very thin. As I looked at her skin, you could see it looked rash, dry, abrasive. I saw spots and everything. And in talking with her, you know, trying to get her history, I asked about diabetes, asked about this and that and the next, and so on and so forth. Now, she said to me, yes, she's diabetic. She had started, or she was having issues with kidneys initially, but she hadn't seen a doctor in maybe 2 years, and she was doing okay, and Anyhow, the minute I looked in her eyes, Dr. Kitty, I knew something was not right. So I got on the phone, I called her physician, and I said, listen, this is what I'm saying. She needs to see you like now. So I sent her over to their office, and he saw her, and after he saw her, he called back, he said, you know, thank God you saw her today because she was in renal failure.
Oh, wow.
Now, she's on dialysis now, today. Since then, the eyes, she's had retinal detachments, lost vision. She would be considered, she's almost borderline low vision. She lost vision totally in one eye from the detachment. The other eye, she can manage to see okay. We have a fit with contacts because in that case, with one eye being reduced and the other eye, to give her glasses is an imbalance. So we're managing her with contact lens in the better eye. And, you know, and she's on medication, and we see her, if she has issues, she has to come in. Okay. We see her, she's stable and she's doing okay now, but she knows if you see anything or sense anything, you need to come in immediately because she only has one good functional eye, and it's affected her life. Fortunately, she's still able to work. But, you know, I also had to have a hardcore conversation with her in terms of, listen, we don't know what the outcome would be long term, but I would tell you to consider looking at Braille, consider low vision products and things that could enable you and help you in the event that you lose the vision in your better eye. And these are hard things that we have to come to grips with in order for patients to understand that, listen, we don't know what the future holds. And, you know, and I say to them, I'm not saying you may lose your vision or whatever, but in the event that it gets to that point, you need to be able to have access to these things to help you function as you move around. So she and I had a good conversation about it. I said, listen, look into these options, learn about it, just in the event, because you never know. So it's disheartening at times when I see patients come in knowing that, you know, and not in her case, but in a lot of other cases, and in the male population in particular, men just don't seem to come in. And when they do, chances are the problem is so bad that you have to almost send them off immediately for treatment or see how you can manage or help them.
Okay. Okay. And that's so great. They always tell us as healthcare professionals that if you screen for something or something shows up, it's malpractice not to provide options for care or resolution. And sometimes we don't like to have those conversations, but having those conversations probably puts the patient, well, not probably, definitely puts the patient at a better position so that they can make well-informed choices and make sure that they're preparing for worst case scenario, like you said, or the best case scenario. But it's good to know that we have healthcare professionals, you know, beating the drum, holding up the magnifying glass, making sure that we're trying to catch all of these small things that may be considered small, but are highlighting a bigger, more systemic issue. So I hope people listening today will realize just how important your eye examination is, making sure that you maintain and keep up with that. So I just want to review the points that you shared. You've given us a lot of good information. I've learned a lot with this. And so like I've been writing notes as you spoke. One of them is definitely know your family's vision history. Which parent, which aunt, which grandmother, father had whatever presenting. If you don't know, at least if they wore glasses, that should put you on alert that maybe you should have some issues to follow up with. Like I said, keep up with your eye examinations. Dr. Jackson said we should start by the age of 5, especially as a child enters school, and probably every 2 years to 1 year, depending on what your family visual history is. Vision history is. Know your numbers, blood pressure, diabetes, pay attention to these things. I just came from a health fair and almost everybody's screening for blood pressure and blood glucose levels. Well, you know, with blood glucose levels, there are times to test, but you want to be vigilant and make sure you have proper testing and screening for both blood pressure and diabetes. Am I missing anything, Dr. Jackson?
No, you're doing fine at this point. It's important for them to see their vision as part of their overall health. Not because you're seeing with your eyes means that everything is okay. And that's what people need to understand, that, you know, the body functions as a whole. And if you neglect one, it's going to affect the other. Okay. So eyes, ears, other parts, they all have to be checked. And they all have to be checked collaboratively, you know.
Mm-hmm. Great. So the floor is all yours. What would you like us to know? Where would you like to direct us? What tidbits you want to share and leave with us as we wrap up tonight?
The final thing I want to talk about, and it's I call it now the new 21st century disease, and that's vision and technology. Okay. You know, technology is driving the world, and it's impacting all of us. And even though we think, oh, third world countries are not, yes, they are, because they're using phones, they're using these gadgets. And, you know, the smaller the gadget, the more it impacts your vision. So you find that technology is impacting our vision today. As I see kids move around and the little babies, they come in and they're just swiping and swiping. And I say to myself, it's good because it's good business. But it's a problem because a lot of times these kids are holding these instruments and gadgets very close to their eyes. Okay, they're trying to watch a movie or something and they're focusing a lot of times. And they don't want to give these things up. And then parents are giving it to them also to pacify them. You know, if you're a busy parent, give them something and they spend their time doing it. Before, we used to play outdoors and then you had the TVs, the screens were bigger and that sort of thing. Now everyone has their own personal item that they use. And as a result of it, because we spend so much time on these gadgets, we don't realize, for one, how it's affecting our eyes. Dry eyes seem to be one of the biggest problems visually going forward today. Okay. And the reason being, because we're staring for so long, we're not blinking as frequently as we should. Then, in most cases, we're either in air condition or using a fan. And that's the environment is compensating and causing the dryness also. And so those factors together, you find that a lot of people are showing with red eyes.
Okay.
Complaining of itching. My eyes feel irritable. And I find here in the Bahamas, everyone seems to have a sinus problem. So a lot of times they go to their physician and they say, oh, it's a sinus or allergies. Yes, the underlying factor, it may be allergies, but the underlying factor that I'm seeing today is dry eyes, because once I stain that patient's eyes, it shows up like a Christmas tree almost.
Okay.
So dry eyes seem to be one of the biggest problems now. And you know, I'm saying my practice is really taken off in that direction, reason being because once I educate the patient as to what's happening, and I say, listen, there's no cure for it. So we have to learn how to manage it. And there are some protocols and things that we have to do. And once I start them down that journey, they're like, they refer somebody else. And they refer somebody else. And so I find today that dry eyes, and which is connected with technology, is one of the biggest problems that we are dealing with today. And you know, when I do my online education or I go to meetings, dry eye is now the biggest topic.
Okay.
How to manage, how to treat dry eye. So I was talking with a rep the other day, and we were having the conversation because in talking about the drug, she was asking me about a particular drug. And I said, I don't bother with that drug because that's only masking the symptom. It's not treating the underlying problem. If a patient is complaining of itching, watery eyes, it could be an allergy, but you still need to find the underlying problem. So I'm not going to use a drug that's just going to pad a problem and not a symptom and not deal with the underlying problem. But if you do more in-depth check with that particular patient, you find in most cases it's dry eye. So once you can manage the dry eye patient, and then you have to tell them in terms of what you need to be doing as you're using these gadgets and different technologies. There are certain things you need to do. And I say it a lot to children in particular, because we can't say to them, don't use it. That is the world today now. I mean, as we progress, everything is going to be digital.
Right.
So it's the way we use these things and how we use it. And so education is key. I am big on education. If a patient comes into my office, I want to explain to them exactly what is happening, why it's happening, how we're going to manage this, and what we're going to do. I am baffled when patients come in and they say to me, oh, I've been seeing the doctor for a long time. What's your problem? They don't tell me. They don't know. So education, Kitty, is key more than anything else, you know.
Definitely.
If we educate our people, they're better able to help themselves. And so I am a firm believer that education is key. So I educate. I do a lot of education in my office. If you come in, by the time you leave there, you will know why this has happened, what is happening, what you need to do going forward. And so education, that is the key for vision and for a lot of other problems that we have today.
So I have an 8-year-old and a 13-year-old at home that are on their tablets because their books are loaded now on their tablets. They have most of their books. We subscribe to the book list. Their homework sometimes requires them to be on the tablet. So what advice would you give me as a mom with young people on the tablet, and even myself, right? What advice to how can we avoid dry eye and these other technology issues?
For one, you notice people like to be on their computers in dim illumination.
Okay.
And you know, that's better on the eye, because if there's an underlying vision problem, you're better off working in dim illumination. At least the impact on the eye is not as great. But I always say to them, you should have some overhead lighting somewhere in your environment. You should not work on these objects in the dark, even though there's a lighting background on the computer or the gadget.
Okay.
Secondly, we don't realize how important blinking is. Blinking is a response that we don't control. And so we just think it automatically happens. But because we're on these digital items with high pixels, I mean, you notice the HD TV, it's so sharp and clear now you could almost walk into it. So we don't blink as frequently. And it's the same thing. The better the technology becomes, we're staring at it. You know, we're so amazed that we don't realize we're not blinking. So when you're not blinking, you're not allowing the cornea, in particular the surface, to be washed, okay, as a result of the fluid that's needed. So we need to blink. I say to patients, listen, blink intentionally. Every 5 to 10 minutes, remember to blink. Okay? You need to take more frequent breaks. You can't sit at your computer for hours and hours and not move away from it. You need to allow your eyes to adjust back and forth with the focusing. So you need to take more frequent breaks. And then it's also important for your posture and how you're looking at these gadgets, and then the distance you're holding them. Some people are close to them. The closer you are, the more impact on the visual system. So you need to be at a comfortable level where you're working, your feet are on the ground, your posture, that's important to enable you to function, because after a while you find your eyes get tired or you get sleepy, and then you complain of watering and my eyes are itching all the time and that sort of thing. But it's a conglomerate of things, and we just need to learn how to manage them properly.
Great. I'm so happy you said this, because when I tell my patients to get up every 45 minutes, they get angry at me. So I usually get them on a routine. My neck, back, shoulder patients, you get a glass of water, especially the ones that are working from a desk the majority of the day. Get a glass of water, 8 to 16 ounces. Drink your water, because you need to keep your water intake up. And
not just that, water is good to help with the eyes also for dryness.
Well, there you go. So their instructions is to drink the water, sit down at least 45 minutes. The bladder has to be emptied. You get up, you empty your bladder, you drink some water, you sit back down, and you keep that routine up throughout the day. And what will happen is now, 1, you get your water intake. 2, you get your frequent breaks, and what we're understanding from you now, you're giving your eyes a break from that constant computer glare. You get some movement and activity in, and get some pelvic health going as well with the pelvic floor, because a lot of us are sitting too long holding our bladders and stressing our core bladder. So I'm so glad you said that. I'm going to highlight this and put this out for everybody to see, because they don't realize just how important it is. Get up and take a break. This has been, I've learned so much. This has really, really been a good show for me. And I'm sure the listeners are really going to appreciate this information, because it's there. We just don't have access to it. I, like you, I really believe in education and bringing it out there for people. The more they know, the better they can take care of themselves, the better interventions we have, better results we'll see. So thank you so much.
Thank you for inviting me.
We need to do this again. We need to pick more topics and go through it, because we didn't realize just how important, overall eye care is. Not just the cute, let me put my glasses back on, not just the cute glasses. All right. So Dr. Jackson, thank you so much. Again, everybody, you can find Dr. Ebbie Jackson at Palmdale Vision Center in Nassau, Bahamas. She's also accessible online. They do have a Facebook page. You can reach out to that. Her email is also going to be listed on the link, so please feel free to reach out to her. You see, she has a wealth of information she loves to share. And now that you've been armed, I'm sure you have even more questions that we can possibly cover in this one podcast. But we encourage you to reach out to Dr. Jackson, to myself, and let us help you recovering the whole of you. That's what it's all about. But also prevention. We talked a lot about prevention, so you don't have to be dealing with the recovery aspect of it. So thank you again so much for your time. Signing off from Recovering the Whole of You, Dr. Kiti Adderley, along with my guest, Dr. Ebbie Jackson. Have a wonderful week, everybody. Good night.
Good night, and thank you.
We hope that you enjoyed the show. To hear more of these wonderful shows on selfdiscoverymedia.com, just look up our podcast genre list. You will see many shows archives there ready for listening. Don't forget to share these wonderful shows. And if you wish to be a guest or a host, or you have an organization that needs to be highlighted, contact us at info@selfdiscoverymedia.com. Bye for now.